Good day, everyone. This is my report, fine needle aspiration biopsy, also known as Fnab. Introduction. Diagnosis of thyroid nodules by needle biopsy was first described by Martin Ellis in 1930, who used an 18-gauge needle aspiration technique. Fine needle aspiration is a technique where cells are obtained from a lesion using thin bore needle and smears are made for cytopathological diagnosis. It is used to diagnose breast lumps, thyroid nodules, soft tissue mass, and salivary glands diseases. For the advantages, it has a rapid diagnosis, it's economical, and it has a high diagnostic accuracy. For the equipment, a syringe holder or syringe pistol most commonly used is the Kameko syringe pistol. Ito siya. The pencil grip syringe holder is another syringe holding device. Disposable 10 ml syringe, disposable 25 or 27 gauge needle with 1.5 inches long. Glass slides with one end frosted para i-label mo. Alcohol prep sponges, alcohol bottles for immediate wet fixation of smears, and gloves. Also containers for cystic fluid collection and transportation to the cytology laboratory, and laboratory slips with the patient's name, clinic number, biopsy sites, and other relevant information to the transferred to the cytology laboratory. So, doon na tayo sa gagawin sa patient. The procedure should be explained carefully to the patient, and all the patient's questions should be answered completely. Also, we inform our patients that the local anesthetic is not used, and that the biopsy will take several minutes, that 3 to 6 aspirations are made, and that we expect no serious complications. Also, patients also ask yung ganito, yung supine position, para mas madali ma-perform yung FNOB, specifically dito sa thyroid na part. So, the patient is asked not to swallow, to talk, or move during the procedure. It is best to talk to the patient and keep him or her informed of the progress of the biopsy. And in this case, the nodules to be aspirated is identified, and the overlying skin is cleansed with alcohol. In other cases, gumagamit sila ng ultrasound. Ito, para makita yung nodule. And 10 ml plastic syringe is attached to a Kameko syringe holder and held in the right hand by a right-handed operator. In this image, 2 fingers of the free left hand firmly grasp the nodule while the other hand holds a pistol grip syringe holder. And in other cases, ulit nga, gumagamit sila ng ultrasound para mas accurate yung pagtama dun sa nodule. And in this image, the needle is then rapidly inserted through the skin and into the nodule. Once the needle tip is in the nodule, gentle suction is applied while the needle is moved in and out with the nodule vertically. So dito, sa ultrasound, makikita natin yung needle, pumasok siya sa nodule, and dito sa image na ito is nag-out yung nodule. This maneuver allows the dislodging of cellular materials and easy suction in the needle during the period of 5 to 10 seconds. Suction is maintained, and as soon as a fluid aspirate appears in the hub of the needle, the suction is released and the needle is withdrawn. And the appearance of fluid suggests that the nodule is cystic. Suction is maintained and all the fluid is aspirated. It is important to release the syringe, plunger, and to remove the vacuum before withdrawing the needle. This allows us to aspirate to remain the needle and not to be sucked into the syringe. So, in this case, yun nga, nag-in out yung needle. Different site siya habang nakapasok. And in this figure, next the needle is detached from the syringe and 5 ml of air is drawn into the syringe. And the needle is reattached to the syringe, and with the bevel facing down, 1 drop of aspirated material is forced onto each of the several glass slides. And after putting 1 drop dun sa labeled na slide, so gagawa na tayo ng smear. Parang sa mga blood smears na ginagawa natin. So, after the biopsy has been completed, firm pressure is applied to the biopsy sites with a 4x4 inch gauze pad. Once bleeding has stopped, an adhesive bandage is placed on the puncture site and the patient is observed for a few minutes. If there are no problems, the patient is allowed to leave. So, I'll show a video para mas magets nyo yung pag-perform ng Fnab.
Hi, today I want to tell you about ultrasound-guided fine needle aspiration biopsy of thyroid nodules. Thyroid nodules are quite common, and about 5% of such nodules are cancer. These nodules are generally followed up with ultrasound. If a nodule is considered to be at high risk for cancer, then a percutaneous biopsy is performed. The most preferred type of biopsy for thyroid nodules is ultrasound-guided fine needle aspiration biopsy. Now let's see how such a biopsy is performed. Our patient is a 33-year-old female. Ultrasound shows a large nodule in the right thyroid lobe. Our goal is to enter this nodule with a very thin needle and obtain cell samples. We will use very simple materials. A thin and long needle attached to a syringe are all we need. For thyroid biopsy, we first numb the skin. Then, we advance the needle into the nodule under ultrasound guidance. When we reach the nodule, we move the needle into different directions while we create a vacuum by pulling back the plunger of the syringe. In this way, we can get samples from multiple sites in the nodule. Then, we remove the needle and inject sample onto the glass slides. These slides are then sent for pathologic evaluation. Now the thyroid biopsy is completed. We can discharge the patient after a short observation. In conclusion, the fine needle aspiration biopsy is a very comfortable and painless procedure that is performed under local anesthesia and ultrasound guidance. The complication rate is extremely low. Thank you very much for your attention.
So, yun yung video about Fnab, performing Fnab. So, for the complications, no serious complications such as tumor seeding, nerve damage, tissue trauma, or vascular injury have been reported. Needle puncture causes slight pain and some skin discoloration at the aspiration sites. So, hematoma is uncommon sa procedure daw. Since yun nga, wala masyadong injury na nare-report. So, cytologic diagnosis. Wet fixed smears are usually prepared with modified Papa-Nicolau stain, which shows nuclear detail. Earlier smears are often prepared with a Romanovsky stain. So, we have 4 categories of cytologic diagnosis. Benign, suspicious, malignant, and unsatisfactory. And the new Bethesda classification has 6 categories, further expanding the intermediate cytologies. So, in this image, ito example niya ng benign cytology. Benign, wala kang makitang anything malignant dyan. Aspirates obtained from multinodular goiters, benign microfollicular adenoma, or normal thyroid are referred to as colloid nodules and show loosely cohesive sheets of follicular epithelium. Colloid blood and rare macrophages. Colloid nodules are the most common cytology and contain an abundance of colloid with sparse follicular cells. There is considerable variation in the number of cells as well as the amount of the colloid present. So, yung next image is yung malignant cytology. If I'm not mistaken, yung mga red ones, yung mga malignant. Medullary thyroid carcinoma accounts for 5% to 10% of the thyroid cancers and may present as a thyroid nodule or neck mass. Typically aspirates from a medullary thyroid carcinoma or hypocellular, composed of large poorly cohesive cells and predominantly spindle-shaped. Amyloid is often, but not invariably, present and there is no colloid. So, punta na tayo dun sa mismong case report ko. Acute suppurative thyroiditis caused by Streptococcus agalactiae infection. So, introduction. A rare case of acute suppurative thyroiditis, also known as AST, due to Streptococcus agalactiae infection, ultrasonography and computed tomography of the thyroid gland showed no specific findings of AST, but culture of both blood and thyroid tissue samples obtained by a fine needle aspiration biopsy revealed S. galactiae, leading to a definitive diagnosis of AST. To our knowledge, only one case of AST due to S. galactiae infection has been reported in the past 30 years, according to PubMed database, suggesting that such cases are extremely rare. So, case presentation. An 80-year-old Japanese woman was admitted to our hospital because of a 2 days history of fever. She had no relevant medical history except for her hypertension, for which she had been prescribed amlodipine. She was taking no other medications. She was a non-smoker, non-drinker. She caught a cold 10 days before admission and recovered 1 week later. 4 days before admission, she experienced general malaise without fever. 2 days before admission, she suddenly developed a fever with 38.7 degrees Celsius with left ventral neck pain. She was examined by her home doctor and prescribed oral cefdinir, but her fever persisted. She was then admitted to our hospital. So, upon the admission, ito yung height niya, ito yung weight niya, and weight, and body temperature was 38, blood pressure was 126.62, her heart rate was 90 beats per minute with a regular rhythm, no major abnormalities except for mild and tender swelling of the left anterior region of the neck. Chest abdominal X-ray films were normal, high WBC count, CRP concentration of 19.41, and the fasting plasma glucose and hemoglobin A1C concentration were 5.3 and 5.5%. Urinary findings were normal. Rapid antigen test for influenza, pneumococcus, and mycoplasma were negative. Thyroid function test showed a decreased thyroid stimulating hormone concentration of 0.18, increased free T4 concentration of 3.06. Ultrasonography revealed an enlarged thyroid gland with a heterogeneous texture and multiple confluent nodule, and a round heterogeneous hypoechoic lesion with a distinct capsule, which was obviously different from the other goiter nodules, and plain CT of the neck also showed multiple nodules in the in the thyroid gland but provided with no further information regarding the inside nodules. So in this case, parang since wala silang information dun sa loob ng nodules, so ano po pwedeng i-perform para malaman if malignant or anong meron dun sa nodules na yun. So, eto na nga. Based on these findings, US-guided Fnab targeting a hypoechoic lesion was performed to discriminate between AST and subacute thyroiditis soon after the admission. Although Fnab did not yield pus, culture of thyroid aspirate needle washed out blood, urine, and sputum were carried out. Although the definitive diagnosis was unclear on admission, oral prednisolone was prescribed due to suspicion of subacute thyroiditis, and intravenous administration of aminobenzyl penicillin was simultaneously performed because of possibility of AST was not completely negated. So on day 2, so nakadetect sila ng gram-positive cocci dun sa blood culture samples, and administration of oral prednisolone was discontinued. So the patient general status was improved, and she became a febrile on day 4, and on day 5, the gram-positive cocci detected from the blood culture samples were identified as S-galactiae. Notably, S-galactiae was also detected from culture samples of the thyroid aspirate needle washout on admission. The urine culture revealed also small amount of E. coli and S-galactiae. The sputum culture detected no remarkable pathogenic bacteria. And also, the S-galactiae strains detected from the blood and biopsy needle washout, and urine showed the same antibiotic sensitivity. Cytological examination of Fnab samples on admission revealed an abundance of inflammatory cells including polymorphonuclear and leukocytes and lymphocytes. So, ito yung image na yan. Also, no remarkable cellular atypia of follicular epithelial cells. Ito sa image na yan. So, on day 6, revealed that the hypoechoic lesion inside the left lobe has had slightly increased in size, and that the internal echogenicity was lower than that on day 1. So, day 10, the patient left neck pain resolved and her WBC count normalized, and CRP concentration normalized since wala na infection, and administration of intravenous aminobenzyl penicillin was discontinued. So US examination was repeated 1 month after the discharge. The size of the hypoechoic lesion was markedly reduced, and thyroid function test results had also normalized. An otolaryngology evaluation and barium swallow failed to reveal a piriform sinus fistula, and at the time of this writing, the patient had been followed up for 6 months with normal thyroid function and no recurrence of AST. So as a conclusion and discussion, conclusively evidence of AST in our case was obtained by culture of the aspiration needle washout on admission. Although Fnab is common procedure for pathological differentiation between AST and subacute thyroiditis, the event experience also suggests that the importance of culture of the thyroid aspirate needle washout as well as histopathological examination of the samples. And the limitation of the report include the inability to determine the genetic identity of S. agalactiae strains and detected from the blood biopsy. And urine and the inability to perform gram staining of the Fnab samples. However, the findings indicate that the usefulness of culturing the biopsy needle washout even in patients with AST who shown obvious fluid collection in the thyroid gland. Hence, this may also helpful for early diagnosis of AST. Since sa case nga na to, after performing yung FNAB, wala nga silang pass or wala silang pass na nakuha. Kaya hindi kagad ma-determine if AST kagad siya. Upon performing yung blood culture, doon na nga nila nakuha yung S. agalactiae. So, in conclusion, we have presented a rare case of S. agalactiae bacteremia following AST. US-guided FNAB of thyroid gland did not yield pus, but a culture of aspiration biopsy needle washout revealed S. agalactiae. Culture could be useful for obtaining a definitive diagnosis of early acute phase AST, even in the patients with no fluid collection in or around the thyroid gland. Because of imaging modalities such as US or CT of the thyroid gland may lack the ability to distinguish AST from subacute thyroiditis. Physicians should know the importance of FNAB and culture for the diagnosis of AST in the acute phase. So yun, this is my report, FNAB.